Let's now move to the next part of the presentation, which is psychiatric assessment. Here we'll look at what is the purpose of a psychiatric assessment and go into details on the aspects of psychiatric assessment. Broadly speaking, we aim to address three issues. One is establishing rapport with patient and caregivers. The second is understanding the problem or making the right diagnosis so that we can choose the right treatment plan. And thirdly, identifying issues that are pertinent to implementing the treatment plan. There are two aspects to gaining rapport. One is gaining the trust of the patient and the caregivers. This can be done by making them feel comfortable so that they open up to you and provide you all the relevant information to make the right diagnosis. We do this by being friendly, approachable, making them feel at ease, showing empathy, and making them feel that they're important. Secondly, it's important to gain their confidence. This can be done by providing adequate explanation, summarizing your formulation, answering their questions appropriately so that they now feel confident in our ability to make the right diagnosis and develop the right treatment plan. The second aspect of psychiatric assessment is identifying the problem and arriving at the right diagnosis so that we can develop the correct treatment plan. In psychiatry, often a symptom or a problem can be caused by various causes. For example, an aggression in a patient with intellectual disability can be due to communication issues, impulsivity, frustration intolerance, mania, depression, or psychosis. It's very important to differentiate and identify the right cause so that we can come up with the correct treatment plan. We do this by asking a lot of questions and by collecting data. In our previous presentation, we went to details about what areas and what questions we focus to help us differentiate these conditions. A link to this presentation is in the flyer so that you can, if you're interested, you can go back and listen to this. Once you make the right diagnosis, the next step is coming up with a treatment plan. The best available treatment for this condition may not always be the right treatment for the patient in front of us. The right treatment is the one that gives us the best chance of success for our patient. For example, in psychiatry, there is a condition called treatment-resistant schizophrenia. For treatment-resistant schizophrenia, clozapine, a medication, is by far the best treatment, much better than any other treatment measures. However, clozapine can cause serious side effects, including seizures, and people need to have weekly blood tests. So even if our patient has a treatment-resistant schizophrenia, if they are not cooperative for blood tests or if they have uncontrolled seizures, then clozapine is not the right treatment. Lastly, the purpose of psychiatric assessment is also to identify pertinent issues that are relevant to implementation of the treatment plan. Let's take an example of somebody with mental illness who also has drug use, uh, living homeless, and has uncontrolled diabetes. So while we can make the right diagnosis and come up with the right treatment plan, unless we address the homelessness, we won't be able to get him to take medications on a regular basis. And unless we address the comorbid drug use and diabetes, the treatment plan is not going to work. Similarly, in people with intellectual disability, we often encounter people with behavioral issues, and for them, the main intervention plan is a behavioral treatment plan that has to be implemented across different settings. Say, for example, this person lives in a busy group home with a lot of turnover, then it's going to be extremely difficult, if not impossible, to implement a complex behavioral plan whilst there is severe shortage of staff and there is a high turnover. Similarly, if this person is also attending a community inclusion program that is quite adept at dealing with physical health issues, and if they don't have the adequate skills in implementing behavioral plan, then trying to implement the complex behavioral plan in a day program or community inclusion setting is not going to work. So an important purpose of the psychiatric assessment is to identify these issues that are going to affect the implementation of the treatment plan. Let's move on to the second part of the presentation, which is assessment, and I'm going to focus on psychiatric assessment. Psychiatric assessment contains two parts. One is information gathering or history taking, and the second part is mental status examination. I'll focus on information gathering. I work in a clinic that's attached to health authority, and hence before I see the patient, I already have access to quite a lot of background information. I specifically look for any assessments that have been conducted during childhood, early adolescent period, or early adulthood. I look for if any assessments have commented on intellectual disability, fetal alcohol spectrum, autism, ADHD, and related issues. I look at who did the assessments, what the findings are, and if the person has had serial assessments, whether the finding has changed over a period of time. I then also look at any previous psychiatric or medical history. If the patient has had previous psychiatric problems, I look at how the problems presented, the course, the diagnosis, and any treatment that the patient received. I specifically look at what worked and what did not work. I also review their medical history, look at any significant past medical problems or current medical problems. I look at the reason for referral and who the referrer is. I want to spend a couple of minutes talking about the role of the primary care practitioner. Usually this is a family doctor or a nurse clinician. They play a very important role in the patient's care even after referring to specialists. They continue to remain in close contact with us. Uh, we specialists regularly update them of our assessment, keep them informed about the treatment that we are providing, and the primary care practitioner continues to remain as the main person responsible for coordinating the care with other specialists, oversee different aspects of the patient's care, and alert us if there are any problems. As specialists, particularly in British Columbia, we are expected to treat and stabilize the patient following a referral from primary care practitioner, and then hand over the care back to the primary care practitioner for ongoing monitoring with some recommendations. So when we get a referral to assess and treat somebody with intellectual disability, the primary care practitioner remains the key person supporting us in this process. Uh, to start with, the primary care practitioner highlights any relevant, important previous problems, may it be psychiatric or medical. Often we do not have access to previous medical problems and medical interventions that the patient may have received, particularly if they've received care from private practitioners, and the family doctors usually highlight them along with the referral. Even before we get the referral, the primary care practitioner usually would have assessed the patient, screened for any significant medical problems that could have caused or worsened the presentation, and they usually do that by doing a physical examination and asking for some routine blood tests. In addition to this, when we are delivering treatment, the family doctor also continues to monitor and highlight if there are any other complications related to psychiatric treatment or unrelated to psychiatric treatment, and inform us of this. So we insist that the patient who has been referred to our team is seen by the primary care practitioner for all the above reasons. Now, moving on to the assessment, the purpose purpose of the assessment is one, to establish rapport with patient and caregivers, two, to arrive at a diagnosis, and three, to identify pertinent points that we need to be aware of to deliver the intervention plan. While we are assessing patients, we adopt certain uh, approaches. If the person has reasonably good communication skills, which is often the case when somebody has mild intellectual disability, then we conduct the psychiatric assessment more or less in a similar way as we would in somebody with general population, with some adaptations such as using simple language, um, uncomplicated sentences, but essentially the questions that we ask are likely to be the same. We often use two types of questions. One is open-ended questions and the next is closed-ended questions. So we generally start with open-ended questions and then move on to closed-ended questions unless um, the patient's communication skill is quite limited and they are unable to elaborate or struggle with abstract questioning. An example of open-ended question would be, say, for example, if somebody is hearing voices, an open-ended question would be something like, tell me more. Um, for the same patient, a closed-ended question would be, whose voice is this? Where does the voice come from? When we see patients who are either nonverbal or have limited communication skills, then we focus on what we see. We look at how they dressed, how they behave in the clinic setting with us, how they behave with other caregivers, what their motor activity is like, what their mood is like, and if they're presenting with any unusual behaviors. The unusual behaviors could be increased motor activity, reduced motor activity, any hallucinatory behavior, which is like talking to self, muttering, or acting as if they're communicating to somebody nearby, any mannerisms, tics, etc. We also attach a lot of importance to interviewing the caregivers. This is often the case because most of my patients have moderate or severe intellectual disability and hence are unable to explain clearly their experiences. If a patient has had a long period of psychiatric illness, then we spend some time trying to identify who is the best person to interview. For example, if a patient has had long periods of being unwell, then I attempt to contact somebody who has known this patient before they become unwell so that we can establish a baseline. I now want to touch upon consent. For me to deliver any intervention, I need a patient to provide me with what we call as informed consent. What that means is the patient has to understand what the problems are, what are the options available, that is, what happens when they get treated and what happens when they don't get treatment. Um, they have to understand the different types of treatment that are available, the benefits and risks of them, and then uh, choose an option. Often the patients that I see in my clinic lack the capacity to consent, and I can't initiate treatment unless I have a temporary substitute decision maker, and the term temporary substitute decision maker is defined in law, who can provide me with consent. Usually, these are family members and friends. Uh, I often request that family members or who can act as temporary substitution makers attend the appointments. Sometimes I get I encounter such situations wherein the patient is living with paid caregivers and the caregivers are saying that the temporary substitution workers do not want to be involved in the assessment and decision making process, or I get told that they completely trust us and they want us to take decisions, and on some occasions they would say that I could contact them separately or email them and they would provide consent. I usually avoid such measures, and I encourage temporary substitution makers to play an active role in this process, and invite them to attend the assessment so that they not only hear about the treatment options but also hear from the caregivers, and through my questioning understand what the situation, what the problem is, so that they can make use of further information about treatment that I provide, and provide me with a proper informed consent. If the temporary substitution makers do not want to be involved, then there are other things that I can do. For example, approaching the public guardian trustee and asking them to act as substitution maker on behalf of the patient. What's important is patients' caregivers who are contracted to provide care through CLBC cannot act as substitution makers. I mainly work with people who have significant intellectual disability and other developmental issues. So my psychiatric assessment is somewhat different to a routine psychiatric assessment in people with normal intelligence. So when I see a patient for an assessment, I aim to find out what aspects of the patient's presentation is due to developmental issues and what aspect is due to an underlying mental illness. To clarify this, I often use a behavioral approach as a part of my routine psychiatric assessment. First, I ask caregivers to define the behavior. For example, when the presenting problem is aggression, I go into details about what they mean by aggression, what exactly happens when the patient is aggressive, and I ask them to describe what they see, what they hear, and other details. Next, I get an idea about the extent of the behavior. So I go into details about the frequency and severity of the behaviors. Third, I specifically focus on fluctuations. So I look for any fluctuations depending on the time of the day. Um, Look at whether this changes depending on where the patient is. Do they change according to staff who are with them, and also look at if there are any certain activities that result in these behaviors. I also focus on whether the behavior fluctuates along the course of the illness. This helps me find out if the behaviors are actually due to additional mental illness or not. For example, in bipolar affective disorder, a particular behavior, for example aggression, may present in one phase, such as mania, and may disappear in another phase. So when the patient is euthymic, then the behavior will disappear and may change in quality and nature in a third phase. For example, if they go through a depressive episode. I also would like to know more about whether these behaviors are associated with other symptoms of mental illness. For example, if the aggression is associated with significant increase in impulsivity or disinhibition, then I'll suspect mania as an additional problem. Alternatively, if if the aggression is occurring in the context of suspiciousness, then I'll suspect psychosis. I also ask questions to identify if there are any other setting events or if there are any particular triggers. Although these are ideally done using detailed data gathering, I do not always have the luxury of having a behavioral consultant assisting me with this process. Further, at the initial assessment, I'm not focusing on an in-depth assessment and concentrating more on screening for issues. Lastly, I also try to differentiate people's observations and get their opinion or inferences on why they think is happening. Often this is difficult, and when I ask them to talk about the behaviors, I sometimes hear caregivers jumping into why they think the person is exhibiting the behavior. For example, when I ask them to describe aggression, they would often talk about the person is aggressive because they need attention. So at that stage, I take some time to explain the differences between observations and inferences. And I say this. Let's look at this in two levels. So the first level is let's describe what happens, which means what we see, what we hear, and what the person does. And then the second level is when we look at why we think is happening, and this usually helps caregivers in differentiating their observations and inferences.